Good evening, friends. Welcome to Tuesday Critical Care webinars. We bring forth such an interesting topics with legendary speakers across in association with Yashoda Hospitals, in association with Hyderabad IDCCM chapter. So for this, I welcome the legendary speakers and senior seasoned speakers, Dr. Ashit Hegde sir, who is head of the Department of Critical Care Medicine from Hinduja Hospital, and I welcome Dr. Gunadhar Padhi sir. He is Senior Consultant Critical Care from Apollo Hospitals, Navi, Mumbai. I welcome you, sir. So, yeah, today's topic is toxidromes and OP poisoning. So, to present this, we have two students, Dr. Swetha and Dr. Ajith. Both are IDCCM students at Yashoda Hospitals, Malakpet. So, they will be presenting the case. As they go on, you can interrupt in between and ask the questions. So, thank you very much. Go on.
Yes. Good evening, sir. So today we are going to present the case. Shall I show? Is it visible, sir? Is
Yeah.
it visible?
Go ahead. Yeah.
Yeah. So, a 36-year-old female homemaker resident of Miryalguda presented to our ER at 6 p.m. on 13th of May with alleged history of consumption of monocrotophos 36 SL of unknown quantity at 2 p.m. near her residence on 13th May.
Fine. So I'll stop you here itself.
Yes, sir.
So can you tell me a bit about monocrotophos? Where does it fall in? WHO has ranked all these poisons. So which group does it fall under?
It falls under class 1, sir.
So ideally,
Highly toxic.
and so any other classifications of organophosphorus compounds, other than of course WHO classification, any other by what kind? There are 3-4 different types of classifications which have clinical implications. So
Dimethyl and diethyl compounds.
that is one. Anything else?
And
What of solubility? What?
lipid soluble and water soluble compounds.
Fine. Anything else? One more. So one is WHO classification, one is dimethyl diether, one is lipid, and this all have therapeutic implications. We'll talk as we go along. But one is oxons and thiones. Okay. Oxons and thiones. Oxons are they don't need to be converted. Thiones need to be converted to oxons, so they're little delayed in action. So these are the 4 sort of broad classifications.
Okay, sir.
So how does this classification is important basically? So like sir told already, like if it is a diethyl or dimethyl, or whether it is class 1, particularly this monocrotophos is class 1A, and so how it is important in categorizing the toxicity and the overall outcome of the patient?
Depending on the lethal doses 50, even a small consumption of this compound, that is class 1, is even oral consumption of less than 5 milligrams per kg is hazardous, and the mortality risk will be more.
So this LD50 actually, how does it what is exactly this LD50?
The LD50 is a lethal dose for 50% mortality, which is the dose in milligrams per kg. This was a study done in animal experiments, rat experiments.
Right. So can you tell me this LD50 of this monocrotophos, how much it actually means, and how much quantity this has been mentioned in a lot of literature is actually lethal?
About 12 mg per kg, sir.
Right. 12 to 14 mg per kg. And if somebody takes by oral route, so what is the toxic dose for the human being? Means approximate toxic dose, lethal dose, I can say.
Less than 5 mg per kg.
Yeah, so it is described that around 1200 milligram is highly lethal, and it's very difficult to resuscitate the patient. So most of this studies what has been said, and what is this diethyl versus the dimethyl compounds? How does it makes an outcome to the poisoning management? Particularly, yeah,
diethyl compounds undergo rapid aging, so early initiation of antidote is necessary. The symptoms wasn't like mortality is more faster, whereas diethyl compounds, they exhibit delayed toxicity and prolonged duration, prolonged effects.
Yeah. So can you just tell me what is the average your that is this aging time for this diethyl versus dimethyl?
Dimethyl compounds age within less than 1 hour, sir, whereas diethyl compounds take about 24 to 48 hours for aging.
Okay, and this monoprotophos falls to which category of this?
It is a dimethyl
Dimethyl.
compound, sir. Monocrotophos is a dimethyl compound. So it is faster. So early administration of antidote is crucial for this poison.
Right.
Fine.
Okay.
Good. Only thing you should also know, WHO actually banned, in most countries have banned class 1.
Yes, sir.
In India, why is it still available in India?
It is a cheaper agricultural insecticide.
It's banned for agriculture. Actually, it's been banned for agricultural use. It only should be used as a. So India has not banned it completely because, like you said, it's cheap, but it's been banned for agricultural use. So ideally, the whole WHO is after India to ban it completely, but because it's cheap, we haven't banned it. But most other countries, including Sri Lanka and all, have banned it. So it's a bad thing for India actually. Anyway,
Yes.
go ahead.
So, history of present illness. Patient had alleged history of consumption of monocrotophos 36 SL near her resident at around 2 p.m. Unknown quantity. Patient was found in a drowsy state and brought by the family. Initially, she was taken to a local hospital within an hour, where gastric lavage was done with normal saline and activated charcoal 50 grams, as per the patient's history. Intubated there in view of respiratory distress. Probable aspiration. She got shifted here for further management with mechanical ventilator support. Started on atropine and pralidoxime infusions there.
So fine. So we'll start with the gastric lavage. Do you agree with gastric lavage for this patient?
No.
What are the pros and cons of gastric lavage for this patient?
Patient is already in a drowsy state as per the history. So
You can intubate into a gastric lavage. That's okay.
Yeah.
Of course, you're right. So if you're doing a gastric lavage in a drowsy patient, you have to protect the airway before you do gastric
First
lavage. That's one aspect.
intubate, then go for gastric lavage. But in
The advantage of doing gastric lavage, even if you're protecting the airway in this patient, what are the pros and cons of doing a gastric lavage? One, of course, you said aspiration risk, so you have to protect the airway. Fine. But if you, so in which patients would you take that chance of, in protecting airway during gastric lavage? In this patient, do you think gastric lavage should be done or not be done? Organophosphorus poisoning.
Since it is an OP poisoning by virtue of its nature increases the gastric motility and thereby gastric emptying. So doing gastric lavage, especially in the Indian setup where the patient is being brought very delayed after being consumption. So gastric lavage may be of very little importance in our setting. But if there is a huge amount of consumption and patient is brought in within less than 1 hour, gastric lavage may be of a helpful role.
So this patient came within 1 hour, so you might say it was possibly justified, but the airway should have been protected. So which drugs you might do a gastric even delayed? Which poisons classically? Generally, after 2 hours, most poisoning is useless. So which poisoning? Conversely, like you said, gastric. Which poisons delay gastric emptying?
Tricyclic antidepressant, sedative hypnotic drugs.
Tricyclic, so all the anticholinergic drugs. Any other group of drugs decrease gastric motility?
Opioids.
Opioids. So that's a two important good. Opioids and anticholinergic drugs. Even datura, bitura, all of that. Any anticholinergic.
Yes.
Okay, not just so you're right about tricyclics, but even so that's about gastric lavage. What about active charcoal? Acha, fine, Gunadhar, you ask me.
No, sir, please continue, sir. Sir, please continue, sir. You want to ask?
Sorry, I'm stopping you again. Please go ahead.
Okay. So my question is like what is this role of activated charcoal in such patients, and what is the role of this multi-dose activated charcoal?
It helps in absorption of the substances which are not and it reduces the systemic absorption, so that can reduce the systemic absorption.
Okay. And as you already told, this is highly effective if the patient comes within 1 hour of the injection.
Yes.
And what is the other have you gone through the intubation notes? What are the precautions during this intubation and mechanical ventilation? What are the drugs you should avoid and what are the drugs you should?
Only thing about activated charcoal, just wanted to say that there are studies which have compared for organophosphoric specifically. whether you give single large dose or intermittent doses or no activated charcoal, there will be no outcome. Last study from Sri Lanka. So you need to say that
Yes.
organophosphorus compound, activated charcoal, at least the evidence is against activated charcoal for organophosphorus compound.
Yes.
Now talk about intubation, what he said about precautions.
So actually, we don't have proper documentation of intubation done elsewhere, sir. But ideally, the precautions we should take while intubating an OP poisoning patient is avoid succinyl choline for paralytic, and because
Not use non-depolarizing muscle relaxants.
and that too, patient may need more than normal doses of non-depolarizing paralytic. Then
Okay, right. Like what non-depolarizing agents normally do you use in your setup? In such
Docuronium.
We use
Doctor, okay. Any during this intubation, and okay, what are the other methods of this removal of the poison? Like have they mentioned anything regarding the your decontamination, like your elimination methods, or the use of the personal protective different devices or agents, and what are the other methods of basically, particularly in relation to the OP poison?
Here they didn't mention anything regarding this case, sir. But generally, while decontaminating things, we have to use a double bagging thing for remove all the clothes which are stained with its secretions to reduce the further absorption from skin. Use a double bagging disposable measures.
How do you clean the skin? How do you clean the skin?
Clean with mild detergent solution, sir.
Soap and water. Anywhere else in the body you worry about? Just the skin and also
Conjunctiva.
Yeah, conjunctiva. So it can be absorbed.
Then use of personal protective equipment for the healthcare workers, including wearing nitrile gloves rather than latex gloves.
Okay, so these gloves are available. I think most of these places these are not available actually. So okay, fine.
So nitrile is available. Okay. So why do they go to respiratory distress? What are the possible mechanisms of respiratory distress so soon?
There are
One is because of increased secretions.
Okay, bronchoria, 1, 2.
Bronchoria. Next is bronchospasm.
That's the same thing. Okay, what else?
And respiratory muscle weakness.
Okay, 2. What else?
respiratory central depression.
Central depression.
Central depression, 3, and 4th, the important one you missed.
Aspirations.
Aspiration. You talked that number 1 actually. He's had a gastric lavage and all that with 4 liters and he was unconscious. So aspiration is much higher on the card. Fine.
So what are the causes of respiratory distress basically? The earliest cause of death, the important within 24 hours, that what the book described is the respiratory failure. So already you have mentioned, like it's a central cause and the peripheral cause. Okay, so any other symptoms and signs you should be looking at in such patients while examination? Have you mentioned after this slide? Or if the patient comes to you with OP poisoning, intubated, what are the other things you should look for?
We have to look for sludge face.
What is sludge? What is?
Increased secretions, salivations, lacrimations, any urination and defecation in the clothing.
What is G?
Sir?
G and E. That is SLUD.
G is GI dysfunction, gastrointestinal motility.
E is emesis.
Emesis and meiosis.
Okay.
So in all the cases you find this meiosis? Is it typical to organo OP poisoning?
No,
No, not 100%.
Yeah. And, yes. Yes, sir. Yes, sir. Okay, so what are the other poisons that causes meiosis?
Opioid, organophosphate, and alcohol can also lead to constriction of pupil.
Any other drugs? Any other which can cause meiosis? Any other condition? Any other poisoning? So benzodiazepines poisoning. Okay. And opioids already.
Okay.
Any other cause of pinpoint pupils with unconsciousness other than poisoning?
Spontaneous hemorrhage.
Spontaneous infarcts or hemorrhage. Of course, the commonest, like you said, is opioids and benzodiazepines. But
So how do you normally differentiate clinically, like for a patient of OP poisoning versus opioid poisoning? So normally, how does the broad limits? See, they will have same pinpoint pupils. They will have bradycardia. They will have respiratory distress. So how do you normally the algorithm?
Usually, opioid poisoning will lead to ileus and retention of urine and constipation, whereas organophosphorus compound toxication leads to increased motility, leading to involuntary micturition and passing of stools, along with constriction of pupils.
And there will be diaphoresis in OP poisonings, whereas there will be dryness in opioids.
Okay.
fine, go ahead.
So coming to past history, she doesn't have any known comorbidities, no comorbs. Personal history, homemaker, and no addictions. Family history was nothing significant. On general examination, patient was moderately built and nourished. No pallor-icterus, clubbing, cyanosis, and pedal edema were noted. When coming to the vitals, patient was shifted in a sedated and paralyzed state. Pulse rate was 142 beats per minute. Blood pressure was 80/50. Saturations were maintaining 100 with FiO2 of 100. Temperature was 103 degree Fahrenheit, and GRBs was random sugars were 134.
Why do you think she has tachycardia and temperature?
Because she was already started on atropine. We didn't know the exact dose, how much was given, and what was in the infusion.
So one possibility is over atropinization. Anything else? Could still be infection, secondary infection. Can patient's organophosphorus compound come with hypertension and tachycardia?
Yes. When the nicotinic symptoms are predominant, a patient can land up in tachycardia and hypertension.
Anything else you want to ask, Gunadhar?
Yeah. So no, very well you have described like the general examination finding. So basically, what is a little bit I just traced upon ki any poisoning patient, ideally you should do like a survey, like primary survey, secondary survey, and that is a much better description in terms of your clinical cases. So it adds to a value. Though you have brightly described all the findings, and that is a good thing. Yeah. And normally, see these patients having tachycardia, bradycardia. Of course, this atropine they have given. So that and why he's hypotensive? Causes of hypotension in this patient. I think the blood pressure is around 80/50. Okay.
One is because of atropine causes cardio depression, decreased output, cardiac output, and the other may be because of increased secretions, losses of third space losses.
And patient is on ventilator support, and that PEEP effect can lead to decreased cardiac output.
Okay. Can there be a chance of secondary infection, as sir rightly told just now?
Yes, sir. There could be septic component also leading to septic.
So normally it has been found that many of the organophosphorus compound, they depresses the immune functions basically. So they are more prone for infection compared to the general population. So there could be a cause. So obviously we'll see the lab, we'll see how the things have the total counts and others, and we'll decide. So does she started on any antibiotic from that hospital?
No, sir.
Okay. Okay.
So on systemic examination, respiratory system, bilateral air entry was present, and fine inspiratory crepitations were noted bilaterally. When coming to cardiovascular, heart sounds were present, no murmurs, JVP was not elevated. CNS examination, patient, we couldn't assess the GCS because she was in a sedated and paralyzed state. Pupils were bilateral 2 millimeters and sluggishly reacting to light. Per abdomen was soft, and bowel sounds were heard.
Spite of atropine and the heart rate going to 150, why was the pupils pinpoint, you think? Does that mean she needs more atropine? Or?
Yes, sir. Because even crepitations are also present. The secretions are not completely cleared off.
That she could have an aspiration, it may not be secretions. No? Already a pulse is 140. No, you must understand is sometimes, especially the organophosphorus spilt on the eye, the pupils may remain pinpoint even if the other things are gone. So don't go only by pupils. And pinpoint pupils are not going to kill anybody. Huh? So you never target pinpoint pupils as your atropine target. Please, nobody's going to die of pinpoint pupils. Huh? You have to target the complications that are dangerous to the life, bradycardia, bronchoria, all that. Pinpoint pupils with a rate of 140, you won't get the pupils dilated because it'll kill him with an arrhythmia. Okay, so. And like I told you, sometimes you can have pinpoint pupils because there is spillage of the poison on the eye. So don't go only by pinpoint pupils. That should not be a target for your therapy. It's just a indicator that he's got poisoning, but not a target for your therapy.
Yes.
Yeah, as rightly told by sir, I think this you must know this killer bees. So 3 killer bees that classically described in OP poisoning. So bronchoria, bronchospasm, and this
Bradycardia.
So these are the issues. So mainly with the patient, we have to tackle that. And of course, the end point of this, how do you determine the end point of this, your atropine dose? So what are the targets? Like, what do you target basically? Do you target the pupil or do you target the heart rate? Or what do you target? Well, I'll give you
Primary aim is clearing
chest.
of chest secretions, sir.
There should be
Clear
no
chest
and,
on
no secretions.
Yeah, so if,
only one endpoint, only secretions.
Other can be heart rate and BP, sir. Heart rate
All three, not just secretions, of course.
Heart rate more than.
What heart rate you target?
On day 1, we target more than 80, sir. SBP more than 90.
Fine, go ahead.
So the diagnosis is clear. It is an organophosphorus compound.
Any other possibility? Only organophosphorus. Any other poison can cause this? Similar some.
Can cause it, but
But history that she's taken the drug, but suppose she's not given you a history. Anything else can mimic organophosphorus poisoning? Any other group of compounds?
sympathomimetics.
Carbamates, okay. Carbamates, okay. It's important. Why carbamates is usually issue. What is the commonest carbamate available in the market in India? The trade name?
Malathions.
No. The trade name of the product, Bagon, huh? Bagon sprays a carbamate. It's important for the treatment. We talk about that.
yeah. So rightly, like in this case, the relative have brought all the bottles and everything, so that could help you to guide the diagnosis. And this patient has been transferred from other hospital, but many of the times this may not be the case. So you have to suspect. So and also most of the times, how do they take organophosphorus during this suicidal poisoning attempt? So most of the times, how do they take basically?
They take along with alcohol, sir.
Yes. So sometimes this lot of like sir told, you have to always suspect the coexisting other poisoning effects also. So that is very important. So that is why you have to always have a broad differential diagnosis. Then you have to come to your provisional diagnosis that this is a likely cause of OP poisoning as per the signs and symptoms.
Because sometimes the solvents themselves are toxic. So pyrethroids and all that. So they may complicate the whole thing. So you should know what solvent was there.
Yeah, that is important also, because most of the times these poisons are not being eliminated by hemodialysis and your hemofiltration, but sometimes hemofiltration helps to eliminate the solvent, what's that called, and most of the times the effects may be because of the solvent what they take. Okay, so that is the reason this is very important, that to know the proper history and a broad diagnosis in these patients. Yeah.
So the investigations ordered here were the routine investigations like complete blood culture.
Okay. So only important is cholinesterase. Everything else is okay. Just talk about cholinesterase levels. Everything else I think is standard. That's okay. No, go to cholinesterase levels and go back.
Yeah.
So what is the value of cholinesterase levels?
The last one. Sorry, asking the last one. Serum cholinesterase level.
It was 273 in this case, sir.
No, we're asking you, not the value of doing the test, not the value.
Okay.
What is the value of doing that test?
What is the importance of serum cholinesterase level in such patients?
It indicates exposure to organophosphorus compound.
So primarily there are two types of assay, right? The red blood cell cholinesterase assay and the plasma cholinesterase. So what's the assay you are talking about? Like what is the importance of red blood cell assay and plasma cholinesterase assay? These two things you have to.
Red blood cell RBC cholinesterases has a high sensitivity for acetylcholinesterases value, and it depends on the dosage and concentration of the product ingested. It is a more sensitive indicator for OP poisoning, whereas plasma cholinesterases do not have that good sensitivity, but they just indicate the person is exposed to a compound, OP compound.
Yeah, so plasma cholinesterase level just tell you that there is an exposure, but the predicting value of diagnosis and your severity doesn't tell you actually.
Do not corroborate with the level of.
I want to clarify that. So that's what. So like he said, most of it has been done, but so RBC cholinesterase is more specific and more indicator of severity, but it's not easily available because that's but not easily. What is more easily available is the pseudocholinesterase, plasma cholinesterase level, and actually that is inhibited much more than your RBC cholinesterase. So actually, it's more sensitive, but it does not tell you about the severity. That's all. To diagnose, if it drops below 25% of the activity, it is indication that this patient is, if it is a diagnostic doubt, and low RBC cholinesterase, low plasma cholinesterase tells you that the patient is, exposed. And also recovery, actually, this is better for recovery than RBC cholinesterase. Because RBC cholinesterase remains low for a much longer time. Whereas plasma cholinesterase levels, pseudocholinesterase levels actually, they start coming up once all the, plasma, this has gone out from the body. So at the moment, I don't think RBC cholinesterase is available easily. So most of us do. I mean, if we do, we do a pseudocholinesterase or a plasma.
Any labs, sir, where these RBC cholinesterase levels are being assessed? Because I have never come across, sir. RBC cholinesterase level. Any labs, sir?
No, I don't think so. I think we're all doing pseudocholinesterase.
Yeah, all pseudocholinesterase. Right. So, as rightly told by sir, like when you give the treatment, the plasma cholinesterase level rises faster compared to the RBC cholinesterase level. And the most important thing, most of these tests, basically, their value fluctuate with the temperature. When you collect the blood, if the temperature varies, sometimes this cholinesterase level also varies. And whenever you do such test, you should have a baseline cholinesterase level for that particular group or particular race, which is most of the times are not available because most of them are farmers. Okay. And the third thing is that it also sometimes indicates your response to the therapy. And of course, the blood should be collected in not in ADTA sample, but a plain bulb should be suffice because they sometimes interfere with the coagulation factors. And the other test, like I just want to highlight this random blood glucose. Anything like any in this patient, is there any chances that the blood glucose levels can fluctuate, or any chances like this patient can go into ketoacidosis or high sugars? Is a big.
No specific relation, I guess.
Not specific, because sometimes this may be a stress induced, but and other things like any role of lipase measurement in this patient. There are only 3-4 papers which has been found that there is a direct correlation between the plasma lipase level and association between the pancreatitis with OP poisoning. So most of them, they affect the pancreas, the myocardium, the nervous tissue. So in that way. So ideally, whenever you suspect like any abdominal pathology, ideally you should send a lipase level. And they sometimes find that this correlates with the severity of the disease.
Okay, sir. So these are the initial labs. 2D echo was showing a normal LV function with a good EF of 65, IVC collapsing. Hemoglobin was, when coming to CVP, hemoglobin was 11.5, hematocrit was 31, TLC is 23,200, platelets are 2.56 lakhs, no coagulopathy, RFTs are within a normal range, LFTs are within a normal range. And this was the initial ABG showing good oxygenation with the PF ratios of about 500.
Okay. So do you expect any? Yes, sir, please.
No, go ahead.
Any do we expect any kind of myocardial problem in such patients?
Yes, sir. It can cause a myocarditis, sir. So leading to cardiac depression.
Okay. And what are the other causes of this myocardial dysfunction in such patients? One is a direct toxic effect, and second is any other reasons in these patients. So like you are using atropine also in a patient who is compromised, is a known case of coronary artery disease or something. In those cases, it can also precipitate the
It can
Uh,
pulmonary
precipitate
edema.
the
It can, it can precipitate the heart failure leading to pulmonary edema.
So here only the WBC count is high, so 23,000. Otherwise, most of the labs are normal. Okay, fine.
This was the initial chest X-ray taken. And,
Can you describe the X-ray? Just go back a little bit. What do you find in this X-ray?
so it is a right rotated film, sir, with a left-sided lung obscured by a breast shadow. So can't really comment on the left lung parenchyma.
Okay. So
This
you
is
said that this patient has a possible aspiration. Okay.
Yes.
But he, okay, so right side looks little clear. Okay. And he didn't have a central line also?
At this time, we didn't insert a central line. It was just after coming from the outside, sir. It was taken in the ER. So on the day one of admission, the serum cholesterol levels which were sent initially were 273. The treatment we put was atropine. We have given in incremental doses up to 40 mg IV, as the chest has still secretions were present, and later we continued at 8 mg per hour IV infusion and injection pralidoxime IV infusion at a rate of 500 mg per hour dose. And
We stop there first. So, but atropine, what are the dosing strategies? You said at endpoints you mentioned about clear secretions and heart rate and BP. But
yes.
how do you start? What dose do you start with? How do you give it?
It is ideal 3 to 5 mg IV loading dose, and increasing doubling the dose every 3 to 5 minutes till atropinization occurs, and later on keeping a maintenance dose of 10 to 20% of the dose where atropinization occurred as the maintaining dose.
Now this patient already had a pulse rate of something, no? What is it, 140? So do you really think it is wise to continue atropine in that rate? Anyway, that's one aspect, okay? Suppose you're given atropine and the patient is very delirious, it becomes rowdy, high fever, like this patient had. What do you do? You're not reaching endpoints, he has secretions, but he's become very agitated.
We can change it to glycopyrrolate, sir.
Why? What's the difference between glycopyrrolate and atropine?
Glycopyrrolate does not cross blood-brain barrier, so that these psychological atropine-induced psychosis can be prevented, sir, avoided with glycopyrrolate.
So you change to glycopyrrolate, okay. But in this patient, like I told you, sometimes secretions may be because of the aspiration of pulmonary edema, not necessarily, unless it's clearly bronchoria, meaning the endotracheal tube and all that is full of secretions. I don't think if the rate of 140, it's a little dangerous to continue atropine because it can lead to dangerous, in fact, or the mortality in the past is because of arrhythmias, not caused by too much of atropine.
Yes.
The pulse of 140, I'd be a little careful about giving. Like everybody said, your targets now are 80 to 100. You don't target, it's very unlikely that by and large that the pulse is 140 and secretions. By and large, I think all three would go hand in hand. By and large, I'm just saying, it's when you have a rate of 140, I'd be a little careful about giving that much of atropine.
And the IV fluids were given at a rate of.
You want to ask something else, Gunadhar, about
Yes. Like PAM, what is the evidence of this PAM in organophosphorus, this particular poison actually? So, do you use in PAM in all the cases, or what the literature says? Like there is a WHO recommendation regarding the PAM. So what is that actually?
Especially for this poison, especially for he said for this particular poison.
Moderate toxicity doses, early presentation, early initiation, and with especially for diethyl compounds. And
So there is a particular dosage regimen actually which is given by the WHO for this kind of toxicity, like 30 milligram per kg.
13 mg per kg loading followed by 8 mg per hour infusion. The literature is ambiguous, sir, but WHO recommends to proceed with pralidoxime in view of benefit. There are two.
Yeah, please. There are two what?
Actually, there are two studies from one from CMC Vellore, which suggested low dose pralidoxime is harmful. But one more study from Maharashtra published in Lancet in 2006 reads that high dose pralidoxime is beneficial. So we are going with pralidoxime in all cases.
So what was the drawbacks of the study from Maharashtra? Not drawbacks, potential limitations, not necessarily drawbacks. You can't. One is that the patients were not really, the group was not that sick, the mortality was relatively low, and most of them came within 2 hours.
Yeah.
That is one thing. And there was a large study, like you said, from Vellore and also in Sri Lanka. You know, in Sri Lanka, what happened? Why did they publish their study about PAM?
There, the most of the compounds are category 3, so they doesn't generally require PAM.
No, they had a shortage of PAM for 6 months in Sri Lanka. And so then they found that the mortality in those 6 months wasn't any higher than. So that's when they started questioning the efficacy of PAM. So the group from Vellore and so it's this controversy you need to know. So if you had to give PAM specifically, which group of patients it might help and which group it will not help. I know we give it to everybody. I mean, that depends on your institute and all that. I mean, you can't be failed, but at least you should know which group it might help, which group it won't help. So one, you said if they come early, yes. Why if they come early, it has a likely to help?
Because if the aging has occurred already, even on administration of PAM, it doesn't really reverse the.
What is PAM? How does PAM act? How does PAM act?
PAM, it will bind at the anionic site and enzymatic site. The phosphorylated enzyme, which was bound to the OP compound, it will help in removal of the OP compound from the enzymatic site and make it available for and make it active again to act.
So what is it? Yeah, this is so it basically prevent the aging. So before the aging happens, you have to give the PAM, right?
So it is more beneficial in diethyl compounds rather than dimethyl compounds, which age very early.
And anything about between water soluble and fat soluble?
Yes, sir.
Monoprotophos is water soluble or fat soluble?
Monoprotophos is fat soluble.
It is a fat soluble. It is a lipid
water soluble. It's water soluble.
So lipid soluble drugs they dissolve into the fat tissues, leading to redistribution and leading to prolonged effects, chronic effects, and delayed effects.
So there may be some effect in them. Okay, so very early diethyl or maybe fat soluble.
Yes, sir.
And monoprotophos, all the three are not there. It is the dimethyl. It is water soluble, and this patient has come a little later. So I'm just saying. So theoretically, because water soluble is absorbed very fast, but it gets out also very fast. So you get very quick absorption, very high peak levels, and the effect is very fast. So aging happens. In any case, both which is dimethyl and water soluble. So in this situation, it's unlikely to work. But like I said, so you have to know the debate.
Yeah.
Ultimately, what you do in your this. Well, the only thing is you should know for carbamates, can you use oximes?
No, sir. Carbamates do not cause aging, so there is no role of pralidoxime with carbamates.
If they cause aging, you can use oxime. No, aging means irreversible binding, where oximes don't work. They are not phosphate. No, they're not phosphates. Oximes only work on the phosphate group, and oximes have a partial agonist action, so it may actually aggravate the toxicity. So in oximes, they are in carbamates, they are contraindicated. Okay. One, because they're not phosphate, they're carbamates, so their action is different, and these work only on the, you only said that displace the phosphate group, no? So,
yes, sir.
And two, because they have a partial agonist action, if you give it for a carbamate poisoning, it will actually aggravate, it will actually mimic the symptoms of organophosphorus. So definitely not given for carbamates. And so basically you need to know the dose and you need to the argument. So one is the Kirti Pawar study from Baramati, of course, and the Vellore study, the Sri Lanka study about oxime. So you need to know the arguments for and against.
Yeah, absolutely. So the two studies are from Vellore, already almost 15 years back. One study is from Pune, Baramati, Dr. Kirti Pawar, and one of the studies is from Sri Lanka. But Sri Lankan studies, there is no benefit of the PAM, as you rightly told, because most of the category of the poison what they use is grade 3 hazardous WHO grading. Whereas in India, most of the poison what we find is WHO grade 1. And there is a little benefit in Indian scenario, particularly this Pune study, which is by done by the Dr. Kirti Pawar. Actually, so this is just for a theoretical knowledge. Basically, when you argue with the you will write your notes and can give some answers, right?
So, and coming to the nutrition point of view, we have started a rice feeds at 20 ml per hour. And oxygenation was cut down to FiO to 40%, PEEP was 6, respiratory rate 18, and tidal volume of 400. For DVT prophylaxis, we have started injection enoxaparin 40 units subcutaneous. Hemodynamics initially resuscitated with IV fluids. In the year, about 2.5 liters was resuscitated, but still the MAP was maintaining at the low end. So we have started noradrenaline support at 0.012 micrograms per kg per hour. There were muscarinic, when coming to the OP features, muscarinic features, tracheal secretions were present, but minimalized by the end of the day. Nicotinic features were absent. We have stopped the sedation and paralysis, and we have looked for any nicotinic features.
Now, what do you mean by nicotinic? When it's paralyzed and all that? Said, what nicotinic feature can you make out?
We didn't continue the sedation after coming to the ICU, sir.
He was conscious and he was moving. There was no paralysis also.
We didn't start the sedation. We wanted to observe that.
No. So you said none was observed. So he was awake.
She was drowsy but arousable. She was moving all the limbs.
Moving all limbs. Power was
moving
good.
all limbs, sir. Power was good.
Okay, fine.
So most of the centers, they use this atropine sheet, while giving the atropine to the patient, they chart like heart rate, the axillary temperature, the secretions, the pupil size, and every time they change the atropine dose, actually that is being mentioned, whether the bolus has been given and whether the infusion has been continued in the same rate or the infusion has been stopped, depending on the patient's hemodynamics. And sometimes these patients suddenly they go into cholinergic crisis after giving a repeated dose of atropine also. That needs to be very, very careful. So one is atropinization and second is the cholinergic symptoms. Both has to be balanced, and over-atropinization is sometimes also happens. So these are the different pathways through this patient they actually traverse. So that is why maintaining a atropine sheet sometimes is very, very helpful in such scenarios. So I don't know whether in your institute it is there or not, but most of the centers now they maintain actually.
There's some question why FiO was reduced to 40%. I presume the oxygen had improved. That's why it was reduced. And if somebody's asked a question,
the initial ABG was taken from shifting. She was transported with FiO of 100%. So we have done an ABG and PF ratios were good. Oxygenation was good. So we gradually cut down the FiO.
Okay.
So looking at your this case history, this patient doesn't have any significant neuromuscular problems. It looks like she doesn't have any fasciculations, not having any peripheral neuropathy or neuromuscular weakness and all.
No, sir.
No, sir.
Okay.
So coming to the day 2, lab showed the hemoglobin of 10, hematocrit of 33, and TLC was coming down 21,720. Platelets were adequate, 2.45 lakhs. Electrolytes were normal. Treatment, we have reduced the atropine infusion to 5 mg per hour dose, and pralidoxime was continued at 500 mg per hour dose. IV fluids were reduced to 75 ml per hour. We slowly increased the RT feeds to 50 ml per hour. Oxygenation was continued with FiO2 of 40. Noradrenaline was weaned off as MAP was maintaining. Heart rate was 126 beats per minute. Tracheal secretions were scanty. No nicotinic features. The patient was slightly irritable, but moving all the limbs on mechanical ventilator support. So we started a sedation with fentanyl.
Okay. So, for example, this patient on the day 3 or day 4 became there is a winning failure, and this patient goes into you put the patient on CPAP, and there is a poor muscle tone, muscle power, neck holding is poor. Now, like in your case, it is all good. So those are the cases which actually require special attention. Like, what are the problems you anticipate? Mostly in day 3, day 4, these kind of problems you anticipate in such poisoning.
One is that is intermediate syndrome, especially with high fat soluble compounds. Redistribution of drug from the tissues occurs after this 24 to 96 hours. So
who first described it? Any idea?
Sir?
What is intermediate syndrome?
Who described intermediate syndrome first? Because India again, Dr. Wadia from Pune, of course, somebody else from Sri Lanka published it first. But actually, Dr. Wadia, because sometimes they'll ask you, especially from Pune. So Dr. Wadia from Pune, from BJ, from Ruby Hall, I think he described it first. Of course, the paper was by the Sri Lankans, but
It is a reappearance of cholinergic symptoms, especially the neuromuscular weakness, which develops in the neck muscles initially, next proximal muscles and respiratory muscles and limb muscles. Usually occurs within 24 to 96 hours.
Cranial nerve also is there. Cranial nerve also.
Cranial. Usually occurs within 24 to 96 hours, but can present in a delayed conditions too. Especially high with fat soluble compounds. The main pathogenesis is because of redistribution of drug from the tissues, lipid tissues into the blood.
Why do you think this patient did not get it?
This is
So surprisingly, this patient has all
And probably
You told, it's water soluble, no? It's water soluble. So it has immediate mortality, but later on, because it's water soluble, it gets out also very quickly. So this is most even fat soluble, no? We told you that, no? So this is a water soluble.
So that is the reason she didn't have any neuromuscular features actually. So,
maybe
what is the treatment of this intermediate syndrome? How do you treat? What is the management plan?
one is
supportive, sir. Continue with the ventilatory support and continue the pralidoxime infusion.
Till how long you continue this pralidoxime infusion?
We have to periodically assess the muscle weakness and continue the.
So many of the centers or many of the studies they have described like continuing the PAM for almost 5 to 7 days, and after the means like the atropine effect is the atropine being tapered off, then they stop the PAM actually in such cases. So in between they always assess the patient, like you have to assess the patient like the different neurological aspect, like how the weaning vital parameters, how the weaning capacity and other things. And early sometimes tracheostomy can also be an option in such patients if they remain for prolonged on weaning failure path. So we have to consider tracheostomy also. And what are the other neurological manifestations of this OP poisoning? Basically, delayed neurological manifestations, the CNS manifestations.
one is delayed OP coma.
Okay.
OP.
Which presents with sudden drop in sensorium of the patient. It mimics as a brain death with absent gag reflexes, cough reflex, and but the only difference is pupils will be pinpoint.
And there are a lot of neuropathies are being described.
Yes.
For this brain thing, how do you treat this? What's it called? DOPE. It's called DOPE, no? Delayed organ phosphoencephalopathy.
Yes, sir.
Treatment, you said, can mimic brain death. How do you treat that? Any idea?
It usually resolves spontaneously. No specific treatment for that. Just a supportive care, continuing the.
Give atropine because it's basically atropine in the brain. You could give drugs across. You don't give glycopene, of course. You could give atropine. Any other drug, which is of the anticholinergic drugs, which is the best penetration to the brain?
Scopolamine.
Scopolamine. So you could try scopolamine. Of course, not available that easily, but. And like you said, what other, Dr. Gunadhar was asking what other neuropathies you have?
Yes.
Organophosphate induced delayed neuropathy, sir. It can affect cranial nerves also and proximal muscle weakness, respiratory.
Not proximal, this is distal. It's different from.
It's a typical like globe and stocking neuropathy.
Paresthesia.
Glove and stocking is not proximal. So it's
Symmetric
distal.
motor neuropathy.
Symmetric.
It's distal. This is whereas your intermediate is proximal. This is more distal.
Yes, axonal.
Any
And
other problem?
any other?
You mentioned 4. You mentioned 1 more is there. Or any more? I don't know. Gunadhar, anything else? 1 more, I think, but.
Yeah, I think they have covered. And most of the time, this patient in chronic exposure, they sometimes have this neuropsychiatric manifestation starting from depression.
And the other thing people have mentioned is extrapyramidal syndrome, with the they can mimic seizures, they can have extrapyramidal, chorea, acetosis, whatever. So there they use, of course, either scopolamine or they use pacitane. Because again, pacitone is simply acting anticholinergic action. So these are the 4 or 5 neurological manifestations of organophosphorus poisoning.
Some have used also hyoscine also, sir. Any experience on that, sir? Hyoscine.
Hyoscine, scopolamine are all the same, but we don't have it. No? I don't know. It's not there in the country. But like scopolamine, same.
Yeah. So like seizures are also very, very common. So most of the time, so seizures are basically common with which group of organophosphorus poisoning? Which group of agents? Basically, seizures, you find a lot of this seizure in patients. So particularly these nerve gases, this Kuman, Sarin, and Taboon, these are very potential to cause the seizures. And how do the control the seizure in such patients? What is the
Benzodiazepines.
Benzodiazepines. So many of this thing literature have described not to use phenytoin, basically because the phenytoin sometimes cause this because it has a membrane stabilizing action. So sometimes phenytoin is contraindicated, and benzodiazepines are the drug of choice in many of the cases of the seizures. So this is one important point. And seizures can also be because of the central toxicity action of the OP poisoning, or a lot of OP poisoning. So this is the thing.
Also, the silent, all this, the solvent or the if they take other drugs like alcohol or parathyroids, even they can cause the seizure. So, so you should know what they have taken. So they can also contribute to the seizures.
Yes. So initially, these agents are being used in which type of now? There are a lot of interesting stories also associated with OP poisoning. Initially, it was used as a biological warfare, and I think recently also Dr. Putin, his aide, one of the close aide, being poisoned by OP poisoning in the flight. So the poison has been kept in his axilla, means silently, and he didn't realize, and he landed up. So the important point is the severity depends on the dose of the exposure. So more dose the patient has taken, like the more is the severity of the problem. So that is what one has to be careful. In the earlier you treat with atropine, and the results are always better. That is the acute OP poisoning. Sometimes the prognosis is very, very good unless until the patient has taken a very, very large quantity of the drugs.
And inhalation is probably the worst. No, inhalation I think is the worst, other than injection. So like nerve gas and all these pesticides. When the wind goes in the opposite direction, they inhale a large dose. So they have a worst. Sarin is, of course, a nerve gas. So that is a different issue.
Yes. Okay. So next.
So on day 3, the labs were normal. TLC came down. Atropine was tapered to 3 mg per hour, and pralidoxime was made intermittent doses, 500 mg 6 hourly dosing. We continued ventilatory support with FiO2s of 40. Heart rate was 106. Blood pressure was 110, 76. Muscarinic symptom features were absent, and no nicotinic features.
Okay.
I think you had a fairly simple case. So I mean,
yeah, they have made the case very simple actually.
I think
so
most of the problems that could arise, of course, basically this patient didn't have intermediate syndrome, and of course delayed polyneuropathies later. And of course, other questions they might ask you is about encephalopathy and intraperitoneal that we've covered anyway. So
yeah, so how do you prognosticate the patient? Like this patient, she came out easily from the ventilator, but many of the patients are there who require prolonged ventilatory support. So there are case reports where the patient is on ventilator for months actually, and you can find all the types of neurological manifestations starting from critical illness, neuropathy, myopathy, prolonged ventilatory support, weaning failure, and diaphragmatic weakness, ventilator-dependent diaphragmatic dysfunction. Everything is possible in such kind of patient. So this is a heterogeneous disease which presents in different forms and different kinds of set of patient. So how do you prognosticate? Suppose this patient is stuck up on ventilator. Now she developed a intermediate syndrome, or then the patient goes into multi-organ dysfunction. So how do you prognosticate? How to prognosticate the OP poisoning patient, basically to the family? Is there any scoring system, or you take something in account and tell the family, yeah, this patient is going to require a long ventilatory support? And how do you explain the family?
Assessing the muscle power daily, and if she is requiring if there was a weaning difficulty, so go for an early tracheostomy to prevent other ventilator-associated complications. And counsel the family regarding the same.
No, the family is asking, like, the doctor, can you tell me whether my patient is going to survive, whether my patient is going to have prolonged paralysis, or whether my patient is going to require how much days of ventilation? How do I tell the family? That is what the prognostication is. So what are the factors that you take in account and tell the family, yes, as per my these observations, probably this patient is going to require a long ventilatory support.
Sure.
So in literature, actually, there are a lot of things are being described. Like if the patient requires a very high dose of atropine, if the patient is having initially the dose of the atropine is very high, or the patient require atropine for a long period of time, and if the patient has significant neuromuscular weakness, and if the patient develop intermediate syndrome with diaphragmatic weakness, or if the acetylcholinesterase levels, the pseudocholinesterase levels initially the drop is very high, and on subsequent treatment and the rise is slow, and of course with the involvement of other organ system. So these are the basic prognostication marker which you can tell the family, yeah, this patient may have some difficulty, and it's very difficult to wean from the ventilator, or they require a long ventilatory support, and the course is going to be prolonged. So this is what.
So on day 5, the atropine was also made intermittent doses at 0.6 mg every second hourly, and pralidoxime was continued at 8th hourly dose. Labs were normal. She tolerated CPAP support with FI out of 40.
Yeah, I think your terminology is wrong. You're saying CPAP with the pressure control. So
PSP.
yes. No, you said PC is 12. So what is it? I mean, the whole terminology, I think, I mean, nothing to do with organophosphorus, but either it is pressure support or pressure control, whatever it is, it can't be CPAP. CPAP is pressure support of 0. No, I'm just saying that's okay.
PSP.
Pressure support.
Then pressure control 12 you can't rate, no?
Yeah, put it around.
Huh?
Yeah.
Pressure support of 12.
Yeah, okay.
12, okay.
Yes.
No, I'm just saying, of course. But in the exam, of course, don't allow them to divert from all, because you mentioned all these things, the whole question gets diverted from the main topic. That's why I shouldn't give them a chance to catch. Even examiners get bored and suddenly they'll pull your leg for some other nonsense. So be careful in your terminology. Don't simply give them a chance to deviate from the main topic.
Yes. So her neck holding was good, cough reflex was adequate. She tolerated SBT and we extubated her. Hemodynamics were stable with a heart rate of 96, blood pressure was 110/70, and no muscarinic or nicotinic features on day 5.
Okay.
So on day 6, sir,
So any further plan for this lady? What else?
Nothing specific. We had we want to observe for any new features, because even most of the patients can present after day 5 also. So we just want to be watchful of any new symptoms developing.
Anything else in the management?
Uh,
No, the psychiatric counseling and all that. I mean, we need to address that issue as well.
Yeah, so many of them have developed some neuropsychiatric illness, as we have discussed after the exposure and after the treatment, after the discharge from the hospital. That is why this is very much important.
Yes. So on day 6, we had kept her under observation in ICU. We allowed oral feeds. She was maintaining on room air. No new symptoms. No respiratory distress. Her vitals were stable. So on day 7, we have stopped pralidoxime and atropine. She was maintaining on room air. No new issues. So we shifted her out of the ICU.
As days go along, I think you can stop atropine at a lower heart rate, because afterwards 80, 70 is enough. I think you'll give atropine for too long. Just saying, maybe.
We have stopped the infusion on day 5 only, sir.
I know, but 0.6 12, etc. also may not be required anyway.
Yeah.
Once the heart rate is being maintained at a certain level, like you said, the first day maybe you'll want a heart rate of 80 to 100. After that, 70, 80 is enough. You don't need a high heart rate.
Okay.
So, you all have any questions, or you all want any doubts to be cleared, or?
So one point from my side, sometimes this patient can have delayed intermediate syndrome. There are cases report of delayed intermediate syndrome after sometimes 10 days also. So whenever you are shifting this patient out of the ICU, you have to little bit extra vigilant and particularly shift them to a little step down unit as far as possible. Of course, for the monitoring for next few days. And they can sudden develop weakness and other things. There are 1 or 2 cases report of delayed intermediate syndromes.
Mm-hmm.
The other question you might ask you, what other therapies have been tried?
Yeah. Magnesium has been tried, sir, and bioscavenger tried. Then calcium channel blockers are also tried. Um,
Any
okay.
role of FFP? Any role of plasma? What are the studies says? Because plasma contains pseudocholine esterase. So do you think that giving a plasma will be a good option to these patients?
But there are no currently human studies suggestive of plasma therapy in OP poisoning.
Right.
And what about rocuronium? Is it can be used as therapy? What is the rationale for using rocuronium as therapy?
Not much. Not.
Again, theoretically, because this is persistent depolarization, they use a drug against that to prevent intermediate syndrome. And so they've tried it in pigs. It's a lot of paper. There were a few papers on pigs. Rocuronium was tried, but of course in adults, not get shown. But it's a has been tried because potentially here is persistent depolarization. No?
Yes.
To use a non-depolarizing agent to as an antagonist to a persistent depolarizing agent, but it's successful in pigs, not shown to be successful in
Humans.
So I suppose, yeah. So you have talked about calcium channel, you talked about magnesium, you talked about plasma, you talked about rocuronium. Some people have tried clonidine also, I think, for the
Yes.
yeah.
And NAC can be given for just antioxidant measure.
Okay.
From the house, there are some questions. I don't know, one or two only, but unless you want to go, you want to talk. How do you treat diluted Baygon spray with kerosene?
Gastric lavage should be avoided, sir, because kerosene can lead to lipoid pneumonia after aspiration, which is difficult to treat. Then supportive care for in view of kerosene, and for carbamate, according to the cholinergic symptoms, we give atropine, sir.
Atropine. Main thing, like you said, very good is aspiration pneumonia. So you might even have to electively protect the airway because you know that kerosene fumes getting absorbed and all that. So essentially protection of the airway. And otherwise, treatment, like you say, kerosene, there's nothing much except lipoid pneumonia or aspiration. And for carbamates, it is the atropine, like you said, no palm.
What kind of smell usually these compounds have?
So what kind of?
What kind of smell?
Garlic smells are strong garlic smell.
Yeah, so one is the garlic smell, and sometimes some kerosene-like smell also being described in many of the compounds. So, okay.
Somebody has asked how to give glycopyrrolate in patients with atropine psychosis. So your targets are not met, but the patient has developed psychosis. So you'd like to use glycopyrrolate. Obviously, the targets are met in psychosis, you just stop, you don't give glycopyrrolate. But
Yes.
targets are not met and he's still psychotic. How do you give? Any idea what is the dose or how do you give glycopyrrolate?
It is a 0.12 mg per kg dosing, IV formulation. Give it at a 12-hourly interval, sir.
Well, early. That's a bit too much, too slow now. Well, early. No, I think the one book, I mean, I get one reference. And another, you might be knowing anything about glycopyrrolate?
Sir, we have not used actually.
No, I got one reference. It is 7.5 mg in 200 ml of saline. Then you start an infusion and you decide you titrate it to your endpoint till whatever you want, basically. Okay. So start with 7.5 mg in saline, 200 ml of saline, and then infusion and titrate to the secretion and your. So that's a starting point. Okay. That's a glycopyrrolate.
The only thing is glycopyrrolate is a little bit expensive compared to the atropine.
So unless the patient is psychotic and your target is not met, otherwise why? Of course not. No question. It's only for that situation. The patient is still having the heart rate which is low, a lot of secretions, but you know he's become psychotic.
Yes. So the and a lot of you know how much atropine sometimes we require in OP poisoning. How much atropine you say?
Take about hundreds of
so sometimes the pharmacies run out of the atropine actually. So
for that there was one paper from Vellore, Dr. Peter. He's mentioned that in those situations he uses adrenaline to, you know, when the heart rate is high, and that brings on the road of atropine much faster and the side effect also. So he has used, of course, this is what you call personal experience, but he has used adrenaline in those situations because it may also be something to do with the nicotinic receptors. So he has used adrenaline, doesn't go up to those mega doses of atropine. When it goes above 100 or something, he uses adrenaline.
European
Yes,
reflector.
There is one paper in 1984 actually published who have used almost 31,000 grams of milligram of atropine actually.
Well,
So
that's
one
what,
study.
so when that's like you said. So what Dr. Peter, I suppose, is the biggest, I mean, maximum experience. So
Yeah.
he would use. Other
Any
questions? Yeah, fine. Go ahead.
Yeah. Any role of this the beta blocker or calcium channel blocker?
Beta
or
blockers should be avoided, sir, in OP poisoning. Calcium channel blockers have been tried.
Calcium channel blockers, they help in preventing the release of acetylcholine from the synaptic terminals by blocking them.
No, the studies are undergoing for recombinant enzymes, actually, which is now being tried in the animal studies actually. So these enzymes basically they deactivate the OP compounds in the blood, like normally how the OP compounds get automatic hydrolysis in the blood. So there are a lot of enzymes. The peroxidase enzymes are being now on trial basis. So this is one update.
Somebody has asked, why was PAM continued till day 6 here? The compound is water soluble. So, I know that's somebody's question. Would you all want to answer? I mean, that's an individual, I suppose. Right now, probably still a controversy about PAM. The people who are against PAM say that for water soluble and all that you don't use it. But I suppose for other people, people who believe in PAM continue to give it. So I don't think there's a debate is over yet.
Yeah, so PAM is not out actually, sir. But only thing is this patient doesn't have any neuromuscular weakness per se, significant neuromuscular weakness.
Maybe he didn't require it. You're right.
Yeah, maybe so.
Because PAM is only for the neuromuscular, like you said. So obviously, no fasciculations, nothing. He probably didn't require it. So any other questions from you all or from the audience? Or
Yes, sir. The audience, yeah, that's enough, sir. Like one question from my side, sir. What is your take on guiding the therapy and repeating pseudochronometry? I think that is generally is not quoted across studies.
No, like I said, mentioned that once pseudochronometry levels will continue to drop until all the drug is gone out of the system. So if they start rising, it probably means that all the drug is out of the system. That's the only, it doesn't, you don't guide therapy on the basis, but it probably means that now the drug is out of the system. So maybe then you can stop your therapies and all that, at least your PAM and all that. What do you say, Guna? That's the, I think that's the.
Yeah. Yes, sir. Another comment is from my side, like many of the patients who are like, for example, on myasthenia gravis on prolonged treatment with this physostigmine and this kind of drugs. Sometimes they mimic the similar episodes.
Yes, sir. Due to cholinergic crisis, they are present.
Yeah, so always when this type of patient comes to with some unknown history and means unknown diagnosis, and you are not sure about the things, always this history should be elicited from the patient.
In past history, if patient is a known myasthenia gravis patient on pyridostigmine, we have to suspect overdose of pyridostigmine.
Conversely, if the myasthenia who takes T20 because of depression, what happened?
Yes.
Suppose the myasthenia takes T20 because takes organophosphate because of depression. What will happen? What will happen? He'll get better actually. You're treating him with a.
What is your personal experience, sir, for this OP poisoning? How many days, the longest survivor?
Honestly, at Hinduja, now we hardly get it. When I was a resident, yes, but now I don't think I've seen an organophosphorus. God knows. I had one, of course, that patient had more of the, CNS symptoms who required, maybe that time, who had more of CNS symptoms rather than anything else. So maybe he required atropine for the CNS. That time, scopolamine didn't occur to me, but maybe I could have given him atropine. But he remained almost a month in coma. More than the other features, he only had coma. Took a long time to come out of that. But that was long ago. Recently, we never had any. It's one of the problems of being in a corporate hospital. You don't see or in a city. You must be seeing more, I think.
So we are getting a lot of OP poisoning patient report from peripheries, and of course we have managed a lot of patients, particularly intermediate syndromes. Also, we have encountered in many patients, and the average length of stay is almost 3 weeks in the ICU, and followed by in the ward. Yeah. So a few of our patients, they have undergone tracheostomy, and now they are doing better. So the mortality is quite low. Only thing, if the patient comes with a very heavy dose of injection particularly where there is severe bradycardia with very low cholinesterase, like the other clinical features like severe bronchuria, bronchospasm, the bradycardia, and other organ involvement, particularly those patients, they didn't make out. But apart from that, the early treatment of atropine, which is actually the wonderful drug of choice, and even if the patient is tachycardic initially, we give atropine the maximum dose as far as possible and double the dose every 5 minutes. That is what the protocol is, and most of the patients, they survive. And that's what I think the main crux of the OP poisoning management. So don't target the heart rate initially, and don't go by a single factor other than you should target the endpoint of atropinization. So this is what our center of experience of.
Somebody's asked about urinary alkalization for decontamination.
Actually, the soda bicarb is only reported in one paper where they have treated the patient with soda bicarb, not for the alkalinization, but for the counteracting this metabolic acidosis and the organ support. Like this is the only one paper is available.
I don't think you're right. So I don't think alkalization increases the excretion. So I don't think
I don't have
alkalization
any-
probably only in the past it was used for barbiturates and salicylates. Even that I think is now controversial. So I think, and of course hemolysis and all that. But I suppose that somebody has asked about prognostication of with the pseudocholinesterase. I think you've taken it, but you can answer it again. Somebody's asked about role of pseudocholinesterase prognostication.
No,
Yeah, we have discussed actually. So yeah, you can comment.
Pseudocholinesterase levels do not corroborate with the severity of the toxicity, sir. But RBC cholinesterase levels corroborate with the severity. So depending on RBC cholinesterase levels, we can prognosticate.
But that's not available easily, so I don't
Yes.
think.
Yeah, so that is not being done. Right. So the pseudocholinesterase only says about the exposure. It
Only
has-
exposure.
And when it starts rising, it probably means that this body, the drug is out of the system. Maybe it's a time that maybe you can start cutting down on your PAM and all that. So can I leave if you don't mind? Thank you very much.
I think most of the answers are being, most of the questions are being answered, sir. Probably, I think any further comments, sir?
No, I think they have done well. I mean, I don't think I have any. I would have passed them anyway. So
No, fairly well presented. Of course, sir has already told. Only few points which you have, like sir has pointed out, that needs to be taken. Okay. And whenever you deal with a poisoning patient, try to go systematically. And whatever being the the survey system is there, the primary survey, secondary survey, and how do you proceed in a systematic manner with provisional diagnosis and differential diagnosis, those has to be kept in mind.
the various toxidromes you should know. I mean, we only talked about one, but I mean, all the various toxidromes, obviously they will ask you. Fine. So thank you. I'm sorry, I have to go for another meeting.
So with this, I think we come to the end of the session. Thank you very much, sir, Dr. Ashit V, sir, and Dr. Gunadhar Padhi, sir, for sharing your clinical experience, and it's very much benefiting almost around 120 people countrywide logged into it, and many more will be viewing it in the future. So, which has benefited a lot. Thank you, Yashoda Hospitals and IDCCM Hyderabad chapter for giving the opportunity to conduct this masterclass Tuesday critical care sessions. And I'd like to thank Dr. Swetha and Dr. Ajith for bringing out a very interesting case where extensive discussion happened, which got the students got benefited. So thank you and good night, sir. Thank you.
Thank you. Good night.
Thank you for inviting us. Thank you.
Thank you.
Thanks.
Thank you. Bye, Gunnar.
Yes,
Bye.
Bye. Bye.
Bye.